So remember one important point. Not all patients have psoriatic skin rash at the time they present with psoriatic arthritis, right? So only 2/3 of the patients have psoriasis preceding the arthritis. So they develop psoriasis and then they later on manifest with arthritic manifestation. That the story holds good for 2/3 of the patient. Among the remainder of the patients, what is the story? 15% of them have psoriasis occurring and psoriatic arthritis occurring within 12 months of each other. Matlab, psoriasis occurs within 12 months, patient develop arthritis, or arthritis occurs within 12 months, patient develop skin rashes. Both are clubbed within 12 months of time, right? Those cases, I can say they are simultaneous in onset. On the other hand, in the remaining patients, psoriatic arthritis precedes skin changes by more than 12 months. And this story is more classical of children. So in pediatric age group, the presentation in the form of psoriatic arthritis preceding the skin changes is more common in comparison to the adult population. I hope you have got the point. Okay, so now let us go on to discuss the clinical features. So far we know the epidemiology, we know the characteristic genetic changes that are associated with this disease. Now let us discuss the clinical features. We will begin that with skeletal manifestation because obviously we are talking about arthritis, right? So in case of psoriasis, the skeletal manifestations can be discussed under 5 distinct types of joint involvement. Now, there would be significant overlap of these presentations, but books continue to describe these 5 distinct types. Okay, what are the 5 distinct types? The type number 1, I think something that is very characteristic of psoriasis, that is the DIP arthritis, isolated distal interphalangeal joint arthritis, which is seen in 15% of the patients. Okay, where else we hear DIP involvement? Right, you're right. So we hear DIP involvement in case of osteoarthritis also, right? So that is one type. Then the second variant is asymmetric oligoarthritis. Asymmetric oligoarthritis. If you are a very stern follower of Harrison, he says it is seen in 30% of the patients, but most of the rheumatology text and the latest literature doesn't agree with this. Actually, the text and literature says that this is the most common type of arthritis that we see in patients with psoriasis or psoriatic arthritis. This is the most common form. Okay, according to most of the literature, they go on to mention that as much as 60 to 70% of the patients would present with this presentation, right? So my recommendation is, if there is an MCQ asking you what is the most common, I would say go with asymmetric oligoarthritis rather than going with Harrison, which says symmetric rheumatoid arthritis like arthritis as the most common, going by his number of 40%. Right? That is what Harrison gives. But I would strongly urge go with asymmetric oligoarthritis as the answer if there is a question about it. Okay. So now we already know 3 types of presentation. The fourth one is axial, mainly spondylitis, right? So that is seen in around 20% of the times. In that case, cervical joint involvement is common. And if at all the sacroiliac joint is involved, the involvement is usually asymmetrical. We are generally talking about symmetric sacroiliitis, but in this case, it is going to be asymmetric, right? The last one, probably the rarest one, that is arthritis mutilans. What happens in mutilans? There is mutilating joint changes, right? So more aggressive joint disease, which is quite rare. So seen in around 5% of the patients. Okay, so these are the 5 distinct types. Before we move on to discuss the radiological features and the extra articular manifestations, I want you to remember these 3 points. What is that? Joints typically involved in psoriatic arthritis, which are not characteristically seen to be involved in other joint disorders, right? The first one is distal interphalangeal joint. We know the only other close differential diagnosis I would think of is osteoarthritis, right? The nodular hand osteoarthritis. Okay. Other than that, temporomandibular joint involvement is also very characteristic, and manubriosternal joint involvement, that is also very characteristic, right? So these 2 I want you to particularly remember. Now coming to extra-articular manifestations. What are the extra-articular manifestations we know? Okay, so let us begin with nails. I know skin involvement all of you know, so I'm not going to deliberate about it, but we'll begin with nail changes. So be aware that nail changes are seen in almost all patients with psoriatic arthritis. Nail changes may not be seen in all patients with psoriasis. So there maybe it is seen in around 40 to 80% of the patients, but 95 to 100% of the patients of psoriatic arthritis have nail changes. What are the characteristic nail changes? The number one is pitting, right? Pitting of the nails, and this more the number of pits that strongly correlates with psoriasis and the risk of developing psoriatic arthritis. So generally some of the resources say that more than 20 pits strongly associated with the risk of developing psoriatic arthritis, right? More than 20 pits per nail is strongly associated with the risk of developing psoriasis if the skin changes are already not evident, and also the risk of developing psoriatic arthritis. We can clearly appreciate the characteristic psoriatic pits, right? And definitely you can notice that in both these nails the numbers would probably easily exceed 20. Okay. Other than that, we can also notice onycholysis, yellowish discoloration of the nails, and also hyperkeratosis. Those changes you can appreciate in the adjacent image, right? You can appreciate in this image hyperkeratosis, distal yellowish discoloration, and onycholysis. So before we move on, just let me reiterate again. Nail changes correlates with the psoriatic arthritis risk in psoriasis patients, right? Okay. Now coming to the next manifestation, that is ocular, right? So what are the ocular changes we notice? Uveitis is known to occur just like in case of any other spondyloarthritis conditions, but generally when we say spondyloarthritis condition, it is usually anterior, right? But in case of psoriasis, it can cause both anterior and posterior. Now I do agree that there are some sources which say posterior is more common, but I have gone through the literature. Overall, it is evident that anterior uveitis is more common even in case of psoriasis. But posterior is something which is not routinely seen in other spondyloarthritis conditions, but here it is seen. So we can see both anterior as well as posterior. And generally, whether we talk about anterior or posterior, when we say spondyloarthritis, say for example, I'm talking about ankylosing spondylosis, I've told you that it is kind of cyclical. So the recurrence is known to occur. So if, for example, the right eye is first affected, then when it resolves, the left eye gets affected. The recurrence is on the opposite side. So it is kind of cyclical or alternating. So in case of psoriatic arthritis related uveitis, it is generally bilateral, so that cyclical doesn't come into picture, and this is usually going to be chronic. So it is bilateral and chronic. So that is one more feature that sets it apart from other spondyloarthritis. Then there is also propensity to involve aorta in the form of aortitis, and this can also go on to cause aortic revegetation. Okay, so these are the extra articular manifestations. Obviously, I have not discussed the skin changes. I believe that it would be covered in the psoriasis video, and I'm also sure that you are all very much familiar with that.